az olması. İngiltere'de de bildiğim kadarıyla önemli bir sorun.
There's another problem, which is shortage of doctors. It's similar issue in the UK, but it's similar issue in Turkey as well.
Türkiye'de aynı zamanda hekim sayısının azlığı yanında diğer sağlık personeli, yani hemşire ve ebe sayısı da göreceli olarak düşük durumdadır.
Turkey challenges not only doctor shortages, it is also shortage of midwife and nurses as well.
Sağlık harcamalarına baktığımız zaman Türkiye'de sağlık harcamalarının gayri saatli transfere oranı 5,4 seviyesindedir. Bu OECD ülkelerinin ortalaması olan 9 OECD ülkelerinin ortalaması 9'dur. Sadece düşük bir orandır.
For Turkey, healthcare expenditure compared with the gross GDP, when we compare OECD countries, Turkey is 5.4, OECD countries is around 9, which is acceptable rate.
Bu dönüşüm, sağlıkta dönüşüm dediğimiz bu işlerdeki başlıca uygulamaları şu şekilde kısaca özetlemeye çalışacağım.
This is the management of healthcare transformation. I'm going to summarize the process.
Tek düzen muhasebe sisteminin kurulması.
Launching the uniform accounting system.
Performansa bağlı ödeme sistemi.
Payments with the performance system.
İşletme yöneticilerinin yetkilerinin genişletilmesi.
Giving the power to the manager.
Sağlık bilgi sistemlerinin yakınlaştırılması.
Dissemination of healthcare information system in all institutions.
Kalite ve verimliliğe önem verilmesi.
More attention to quality and productivity in hospitals.
Hastane bütçelerinde disiplin sağlanması.
Ensuring budgetary discipline in revolving fund institutions.
Global bütçe uygulaması.
Implementing the global budget.
Yöneticiler için performans uygulaması.
Performance practice for managers.
Hizmet alanlarının yakınlaştırılması.
Determine the number of personnel to be assigned for personnel-based service procurements by dynamics and realistic criterias.
Stok yönetiminin geliştirilmesi.
Limitation for the profit ratio to be allocated for the contract for personnel-based service procurements.
Yine stokla ilgili diğer uygulamalar, satın alma yönetimi.
Procurement management.
İşletmelerin finansal risk esasına göre yönetilmesi ve iç kontrol sisteminin kurulması.
Managing institution financial risk management principles and setting up another management system.
Sağ koordinatörlüğünün ilk kez belki dünyada geliştirilerek izleme değerlendirme sisteminin etkili bir şekilde yapılması.
Field coordination system and enforcing the monitoring and evaluation effectively. This is the first in the world applying in the country.
Hizmet alanlarının yaygınlaştırılmasını biraz daha açmak isterim burada. Bu bizim önemli bir sac ayağı olacak hizmetlerin geliştirilmesinde.
Another element is procurement process, and I would like to give more detail about that because this is a very important leg of the process.
Mesela Türkiye'deki Birliği gibi, USG gibi birçok hizmetin artık hizmet almayla yapıldığını görüyoruz 2003 yılından itibaren.
Since 2003, magnetic resonance, CT, and ultrasound services has been purchased by the government via service procurement method.
Bu yöntem özellikle bu cihazların verimli bir şekilde kullanılmasına yaradı.
It does have to improve productivity of the usage of those devices.
Tabloda da MR cihazı başlangıçında çekim sayısının 2 katına çıktığını görüyorsunuz.
You can see on the graph usage of MR equipment almost doubled. It has been used effectively.
Aynı durum BT'de de söz konusu benzer.
It has similar usage with the CT.
Bunlar bu hizmetlerin fiyatlarına da düşmesini sağlayacak.
It does help to reduce the prices as well.
Yani MR ve BT için kamu ödediği fiyatlar bu dönemde azaldı.
Public sector paid less than before per diagnostic treatment.
Son olarak
Mesela
MR ve BT maliyetlerini değinmek istiyorum Türkiye'deki.
this is the cost of MR and CT prices.
Türkiye'de bir MR 15 euroya, bir BT 10 euroya, Dr.Halil ise 3 euroya mal oluyor.
This is the price of MR, 15 euro. CT is 10 euro. Dr. ultrasound is 3 euros.
Bunu bu tür şeylerde MR'ın 250 ton üstüne koyduğunu İngiltere'de biliyoruz. Buradan mukayese yapabilirsiniz. Ne kadar büyük fark olduğunu.
You can compare with the UK prices. In the UK, MR, cost of MR is starting like 200 pounds and above.
Teşekkür ediyorum. Kısa dönemde sağlık sistemindeki değişmelerle ilgili bazı noktalara değinmeye çalıştım.
I would like to thank and I would like to explain shortly the reform in limited time.
Bu çok yeterli değil ama elimden kadar anlatmaya çalıştım.
This is not good enough, but this is the time limitation. I have done my best. Thank you very much. I would like to thank Mr. Atasever. He has a critical role in Turkish health reform. And of course, we are going to have question time and also this session. So you are more than welcome to ask anything you would like to answer, because he has at his forward also. He has written about the Turkish health reform, and that's why he is here. You are more than welcome to ask any question you have. Now, just I would like to welcome Mr. Ali Demirbag. He is our previous chair, and also he is Haringey deputy mayor. After May, he is going to be mayor of Haringey. So his contribution to ITSEB is always valuable, and I appreciate you made it to be here. A very quick presentation. I think one you are trying to find it. Is everything okay? Yes. Yeah. Okay. I will start.
Chairman. Mr. Chairman, ladies and gentlemen, I would like to thank the organization committee for inviting me to this nice, exciting meeting. It's nice to be here. What I'm gonna talk about today is it's gonna be a heart-to-heart talk. I will talk about heart disease. It's the #1 killing disease all over the world. Same for the UK, same for Turkey, same for the rest of the world. When you look at this question, which letter would you choose as a correct answer? A, heart attack, B, stroke. Yeah, they both constitute the cardiovascular disease, and cardiovascular disease means disease of the heart and disease of the vasculature circulation. So these two constitute the most important and the most prevalent killer. What about the rates? You see in 2011, this is the statistics from World Health Organization, heart attacks and stroke, again #1, and it's gonna be all through 2050. Afterwards comes the lung infections and chronic obstructive pulmonary disease, cancer, but again, just the first two cardiovascular disease. Do you recognize this lady? Of course you do. You remember this musician, Louis Armstrong? Yeah, you remember this lady, yeah? Yeah. Louis Armstrong, you remember him? Yes. And this was our former president. I'm sure you know this gentleman. And I'm sure also that you know this gentleman. He has a cigar named by his name. What is the common point between these people? They all suffer cardiovascular disease. What does cardiovascular disease do? It just steals 10 to 12 years from our lifespan. If you get a cardiovascular disease, if you get an MI, or if you get a stroke, you just lose approximately 10 years from your lifespan. So it claims more lives than the sum of all cancers. More than 17 million deaths per year. And it's going to be more than 24 maybe in 2030. And most of these deaths occur in low and mid-income countries. What about UK? The situation in UK is not that different. More than quarter of all deaths in the UK are due to cardiovascular diseases. 1 people every 3 minutes die of heart disease. Oh, it's not going to happen here. And increasing urbanization is still the main factor. Why is that? Because the unhealthy lifestyles of the urban living causes this. Our kids, our children will suffer again because of this. In 1900, 10% of the population were living in the cities, but now half of the population living in the cities with these unhealthy lifestyles. What about the top 10 countries? Highest cardiovascular disease rates in Russia, Ukraine, Romania, Hungary, Cuba. You see all low and mid-income countries. Well, what about the causes of the heart attack? We can divide it into two. One is the unpreventable causes. That means we can do nothing because it's because of hereditary. What does that mean? If your parents have heart disease, then you have the risk to have it. You cannot modify it. You cannot change it. This is hereditary. Women, before menopause, they are protected. They are immune to heart disease. But after menopause, women and men get the equal chance. The age. Men more than 45 years old have the risk, increased risk. Women more than 55 years old age get that risk also. What about the preventable ones? First one is the diabetes. The other one is the obesity. And then the high cholesterol, high blood pressure, hypertension that we call, excessive stress and smoking. They are all preventable causes of heart disease. I'm going to talk about them a little bit more. This is the estimations for 2015. 7.5 million patients will die due to heart disease. It's hypertension. 6 million due to smoking, 2.8 million due to obesity, and 2.6 million due to high cholesterol. Huge number of deaths, all leading to cardiovascular disease, and these are all preventable, as I said before. So when you look at 2001, and after 10 years, 2011, the high pressure deaths increased more than 40%. And hypertension is a curable disease, is a treatable disease. What about the situation in England? Out of 10 hypertensive patients, just 4 are undiagnosed. They don't know that they have hypertension. 2 of them, out of 10, 2 of them, they know that they have hypertension, but they don't get the right medications. They are not under control. 4 out of 10 only gets the right medication, and their blood pressure is under control. So what about the situation in the world? Yes, hypertension is a treatable disease, but poorly controlled all over the world. Why do the hypertensive patients die? Half of them die due to heart failure and acute myocardial infarction. 1/3 die due to stroke, bleeding in the brain. And 1 out of 10 approximately die because of chronic renal failure. These are all cardiovascular diseases. Can we manage it? Yes. We can adapt to a healthy lifestyle. We can modify our lifestyle. We should lose weight. We should change our diet to vegetables and fruit mostly. We should restrict salt ingestion. We should exercise more, and we should decrease alcohol. Don't put salt. Salt is the main reason for hypertension. Okay, what about the second preventable cause of death? It's smoking. Just quit smoking. What about the third one? It's the LDL, the bad cholesterol, low density lipoprotein. What does it do? This man is having chest pain right now. And he's just doing this gesture. It's very typical for acute myocardial infarction. Sorry. Yes, he's having acute myocardial infarction right now. What does that mean? This is because of high cholesterol. Can you play it? When you feel that, just before. Can you just click on with the mouse? Yeah. Yes, you see the lesion over there? It's narrowed there. So this man is having a heart attack. He just came to the hospital. Next. We just put a stent there. Next. Just click on the image now. Yes. And the problem is solved. This is what cholesterol does to your arteries, heart arteries. Next. If you eat like this, you will probably get 1 stent. If you eat like this, it's for sure that it's going to be 2 stents. And if you are eating this, okay, I have to put all the metals all over your arteries, full metal jacket. If I ask you which one of them would you like to be, I would prefer to be a monkey, not the lion. Why? Because Monkey never eats cholesterol, just eats vegetables, fruit, no meat, no cholesterol. And the cholesterol level, the LDL level is there, 40 to 70, very low. And they will never encounter a heart attack. They will never experience a heart attack. But lions, they do because of heart attack. Okay? So what we're gonna eat? All natural, no fat, no cholesterol, no sodium, no calories, high fiber, no chemical additives, and we spiced it so you would never know it was just sawdust. So shall we eat this? No. There is a miraculous cuisine, Mediterranean cuisine, which is very healthy cuisine. You see all vegetables, fish, olive oil, and the grains, and if you like, of course, wine. Number 4, preventable causes of death. Diabetes. Diabetes means vascular disease with hyperglycemia. And nearly all of the diabetic patients die of cardiovascular disease. And the most important risk factor for diabetes is obesity. Look at that picture. Next. If you eat an apple, it's just 60 calories. But if you eat those pistachios, it's 10 times more, 600 calories. And you know how long you have to run just to burn out that pistachio? You know, you have to run for 4 hours just to run. This is why we are eating these high calories. Next. But if you eat these, you see the calories, just 2 digits. 15 calorie, 26 calorie. Yeah, lettuce. You see, if you eat these, you will stay lean. Next. And number 5, preventable cause of death. It's obesity. In the urban life, we're just sitting in our armchairs, watching movies, we have our remote controls, we are not moving, we are not exercising, we are getting fat. Next. We are all like this when we are 18 years of old age. But we quickly become that shape, into that shape. Why is that? Because our metabolic rate increases every year, beginning from 18 years of age. Next. And we never exercise. We drive our cars, we never walk, we never do exercise. We should exercise more and more. Diet. Diet is not a nice word. If you say diet, and if you do it for a couple of months, couple of years, afterwards you just get bored. It shouldn't be a diet. It should be a lifestyle. You should be, you should adapt yourself to a healthy lifestyle. What about the caveman lifestyle? They were all lean because it's impossible for them to hunt that mountain and eat meat. They can only find veggies around, and they have to protect themselves. They have to run from the wild animals. They were doing daily exercise. So this is the caveman's life. Diet or lifestyle. Diet makes you unhappy, and you will lose weight because of crying. It says. Is there a miraculous food? You see them every day in the papers? No, there is a miraculous cuisine. You recognize these guys? They are Dalton gang, Dalton brothers. They were robbing the trains, the banks, in the 19th century in the United States. I call them, I made an analogy and I called them cardiovascular dead gang. This is smoking, this is cholesterol, this is diabetes, and this is hypertension. They steal 10 years from our lives. They are the cardiovascular gang. And you recognize this guy? This is a good guy. It's me. I'm fighting against cardiovascular disease, trying to do my best. What is your life expectancy? 50 years or 90 years? You can just increase it from 50 to 90, just obeying the rules here. Just getting a healthy lifestyle. Okay, when you get 90, is it the end of life? Is there life after 90? Yes, there is. We own the world record. If you get that old, you get a new disease. It's called aortic valve stenosis. It's a senile aortic valve stenosis. And at that age, it's impossible for you to get a surgery for the aortic valve replacement. So we just implanted a valve to this gentleman, young gentleman, a couple of years ago. And he's doing fine right now. But we did this without surgery. We just did this with, as we are doing coronary angiography from the leg vessel. Can we Yes, this is the vessel in your leg. We just get into that vessel next. And this is the, just keep. And this is the aortic valve, your new aortic valve. I'm turning the aorta right now. I'm getting into your heart. Next. Yes, now the valve is, you see the metal there, the valve is just on your own original aortic valve, and I disrupt the valve with the balloon and put the new valve there. Next. And the procedure ended. Next. And I check the result, the valve is functioning. Okay. Next. Okay. So, are you good at numbers? Do you know, I'm sure that you all know your mobile numbers, mobile phones. You know your credit card combinations, you know your shoe sizes. But what about your cardiovascular risks? Do you know your blood sugar? Do you know your blood cholesterol? Do you know your blood pressure? You have to know these. If you know these and if you modify these values, then you will live long. You should exercise 5 days per week, 20 minutes per day. What is the take-home message? Get regular checkups. Know your risks. Modify your lifestyle. Quit smoking, eat healthy food, lose weight, and consult your doctor. Take-home message too. Remember, heart disease is a preventable disease. Thank you for your attention.
Dr. Timur Timurkaynak, and he is, we have, as I would like to note that one, we are from University. When I was a student, Dr. Timur Timurkaynak was our senior registrar, right? And we learned a lot from the University's cardiology department. Just I think it is right to mention Dr. Yavuzer. She was a fantastic individual. It's not only she was great for the cardiology, she was one of the ethical idols for us. I'm sure Dr. Timurkaynak will remember that. So again, it was a fantastic presentation, and this is one of the great example of Turkish almost this is not the massive surgical operation. Normally it used to be a big surgical operation, but now it is shown how advanced cardiology in Turkey, and thank you very much for contribution to Turkish medicine and science. Now, may I ask Dr. Figen Karadag to present chemical addition, please. Thank you.
First of all, I would like to thank to ITSEB for inviting me for a nice meeting. This is the first time for me, so I really let's see. So sorry for my voice. And this is the first time for me for this kind of presentation, so I don't have any preparation for the presentation because I have to see my But the rest of the majority of individuals who gamble so far recreational report no significant financial consequences or any difficulties control their habit. It's very important part to say an addictive habit. It means somebody has out of control of his behavior. So most of the people don't lose their control. But some people, it is estimated to be 0.4 to 5.3% worldwide, develop a maladaptive form of gambling behavior, which is associated with impaired functioning, reduced quality of life, high rates of bankruptcy and divorce. Gambling disorder usually begins in adolescent time or early adulthood. It is very important because all kinds of addictions start in adolescent period. That means prevention studies has to start in adolescent time. Males are tending to start at an earlier age according to human or the other populations. Gambling is a continuum. There is on one hand, there are some people who never gamble, and on the opposite side, there are people they gamble all the time. And the other gambling styles can be placed on this continuum. Some people gamble for experimentation, and then they keep going gambling, and they become social gamblers. And if they keep going on gambling, so they are in at-risk groups, and then problem gambling is starting, and then pathological gambling replaced that with gambling addiction. If we have a look at the definitions of those terms, problem gambling is gambling behavior which causes disruptions in any major area of life, either psychological, relational, physical, or social life. In pathological gambling, there are persistent and maladaptive gambling behavior which results in loss of control over gambling, and pathological gambling is also called compulsive gambling or gambling disorder. There are some differences between social gamblers and problem gambling. A social gambler thinks about gambling occasionally, but the problem gambler are really frequently preoccupied with gambling. Social gamblers do not play for weeks, and they have some money limits. They can stop themselves. But in problem gambling, they play for weeks, and they borrow money, and they don't have limits. And a social gambler starts to gamble. They hope to win, but they can expect to lose. But in problem gambling, the gamblers always hope and expect to win. And a social gambler can take or leave the game, but in pathological or problem gambling, they have the primary source of fund is gambling, so they don't try to stop themselves. Gambling has traditionally been dominated by the male population, but now participants include women, old age population or young population. Young population and women is also very important, and this change in demographics is because of the change in perception about gambling, because gambling tools are changing in time. In the old days, casinos or playing cards is the most important tools for gambling, but nowadays the gambling tools are really changing. Electronic gaming machines, for example, are becoming increasingly popular in modern casinos. They are user-friendly and it's really easy to operate them. part of gambling problem because they are increasingly being exposed to gambling opportunities on the internet, in the community, at home, in their peer surrounding. So it's not surprising that problems associated with gambling are being seen in youth. There is a very interesting study. It's just maybe lasted 10 years. It started in 2001 and it's ended in 2010 on an student study. It's really very important sample size, as you see on the slide. Over 50,000 students included in the study, and 6th, 8th, and 11th grade youth were included in the study. There are very interesting findings of this study, but the most important part, there are a lot of targeted risk behaviors in the study, but 3 of them really increased in prevalence between 2009 and 2010. The 3 were gambling, marijuana use, and depression. And gambling really represented the largest increase in those targets. Not many people talk to youth about the potential risks of gambling, especially when compared to substance abuse education. It is very important, not because prevention studies should be in such a kind of education. Students who indicated that gambling also demonstrated higher rates of alcohol use, marijuana use, smoking, and depression. We can see those kind of problems in younger population. Does this mean that youth who gamble also drink, smoke, use drugs, and are delinquent? The answer is simply no. But it means that those kids that gamble also tend to participate in other high-risk behaviors. And those who use drugs, drinks, smokes, and are depressed are at high risk to develop gambling problems. It means that whenever a unit on substance use is introduced in the classroom, gambling should be included. It's really very important because when I started preparing this presentation, I read an article. It was really interesting because the high percentage of gambling acts on being. It was really increased in the last 2014 and 2015. In the last 1 year, about 15%. It was increased. The acts on gambling, and so it's easy to reach such a kind of websites. And mobile phones are the most popular tools to reach gambling. So there are a lot of opportunities to prevention gambling problem in youth. It's really very important. Thank you very much.
Of course, gambling is one of the important issues, especially in the Turkish community we are aware of. That's why your point, especially easy search, is one of the problems. When you look at our IRO, you can easily see number of gambling places and also that applications same as well. Of course, again, we are going to have question answer time.
May I ask Dr. several questions to your presentation?
We are doing really good in terms of timing. Thank you very much for every doctor who is giving up their time. Thank you very much.
Dear members of the Parliament and guests, I
Atasever, academic from Istanbul, Turkey. I have been practicing medicine for 30 years in the specialty of gynecology and in vitro fertilization. And I have the in vitro fertilization center that has been serving in IVF since then for 20 years. As you may know, the first IVF baby, Brown, was born in England in 1978 as the result of the studies conducted by the valuable British scientist Edward and Patrick Steptoe. They introduced in vitro fertilization treatment for the first time in the world at home clinic in Cambridgeshire. Until today, many scientific developments have been obtained in IVF since then. Although it is a very specific medical area, in vitro fertilization resonates greatly around the world because reproducing is one of the three basic things of all living besides eating and sharing. Nowadays, IVF treatment is applied with very advanced technique both around the world as well as the Turkey. Many serious infertility problems can be treated and viable solution can be ensured. Infertility rate around the world is 10 to 15%. In other words, 1 in every 6 married couples encounter with infertility problem. According to Asia data of 2014, more than 5 million IVF babies were born. During the period of 20 years, more than 3,000 babies were born in our clinic. Today, with the help of recently developed techniques in IVF treatment, we are able to directly intervene into the reproduction cell, namely the oocyte and sperm cell. At our clinic, we are able to apply many advanced techniques such as intracytoplasmic sperm injection, improving sperm selection result by magnifying the sample under the microscope 7,000 times, blastocyte transfer, transferring 5th or 6th the embryo, embryoscopy, improving embryo selection, result by monitoring development of embryo via camera, freezing sperm oocyte and embryo, PGD, pre-eclampsia, genetic diagnosis, treatment methods, assisted hatching, thinning external wall of the embryo, immunity vaccine, immunotherapies such as paternal lymphocyte vaccine, lethargic disease, commonly known as lobster baby syndrome, is the state of not having a second congenitality and genetic condition inherited from parents. By successful application of PGD at our clinic, we have been able to select healthy embryos from the patient couple. Healthy babies were born for the first time in the world from patients with the genetic condition in our clinic. 2 sisters carried this gene, were married with 2 brothers carrying the same gene. They have been referred to us from Australia. Previously, they lost their babies 3 times due to that disease. In the first PGD treatment, each couple obtained 1 healthy baby girl. In the second treatment, one of the couples obtained 4 twins. Similarly, other genetic disorders such as Mediterranean anemia, also known as thalassemia, myasthenia gravis, myelinosis, and cystic fibrosis can be avoided with this technique. By choosing the healthy embryo transplantation can be cured with in vitro treatment at our clinic. I hope that successful results will be obtained in the stem cell studies, which are in progress and seen as the endpoint of the infertility problem. While finishing my speech, I would like to express that I am proud of being a doctor. I believe it is one of the most prestigious professions in the world, with the purpose of serving to people without any racial, religious, linguistic, in broader discrimination. I would like to celebrate everyone's Doctor Days and remember interested our great leader Atatürk, who provided the right of education to women in our country, has the opportunity to practice important professions such as physician. I would like to valuable members of the Parliament, guests, press and organization committee who showed the Turks of esteem to me.
Thank you very much. So, of course, today we have few IVF. The reason we have chosen IVF subject is not coincidence. There are many couples that are having problems, and we have number of births, and they are trying to find a way to have a baby. Unfortunately, NHS has one of the challenges in IVF treatment. There is still post-op lotteries going on, and also some age limit in order to have a right to baby or get treatment from NHS. So having that facilities ready with the cost-effective opportunities, just I would like to thank the speaker and her colleague. They have done a great job for those families who wish not to have a baby. And we ask Dr. Halil Ibrahim to clarification this. Okay, because of the his journey, probably he's not giving that great. To avoid further discussion for you, Dr. Ibrahim Tekin's practice is going to do the presentation on behalf of him.
Why patients come to Cyprus for IVF? Cyprus has a huge medical tourism going on at the moment. There are about 12 to 13 IVF clinics in Cyprus. Now, there are many different laws relevant to IVF around the world, but not many restrictions in Cyprus, which is a big reason why a lot of patients come to Cyprus, as well as pricing and other things. One of the restrictions that are obviously in the UK, again, like he had said, is age. We have a lot of patients coming from Turkey as well, being so close to the island. One of the restrictions there is having a single embryo transfer. We do have a lot of patients who are coming for that reason. Having more embryos transfers will give them a higher chance of pregnancy. One embryo doesn't take, perhaps the other one will. That also does give us a slight higher risk at twins. Which we also do have a limit of. Our success rates are also quite high compared to everywhere else at the moment. 78% is our pregnancy rate now. In the UK, as of last year, from what I have read, I don't think there's been, from the HFEA base, above 30%. It's a very big difference, and it's why we get a lot of traction from the rest of the world. So this is a picture of one of our clinics at the Near East University in Nicosia. Just some small pictures from the clinic reception area. And one of the smaller patient rooms. So we've been in association, Dr. Tekin has been working for 18 years, establishing himself, which is quite a long time. We've been working together as UKCFA, now is Abbey Fertility, for 5 years now, providing care between the UK and Cyprus. Now, liaising between the two has been very streamlined, very easy process for both patients and the doctors referring. We'll go into that in more detail in just a moment. Treatments we provide, these are just some of them: IVF, IUI, PGD, PGS, surgery, egg freezing, sperm freezing, of course, family balancing. We do have, as time changes, a lot of patients seem to be wanting children at a later age in life as well. So IVF is starting to be a lot more recurrent, I'll say. As patients at the moment, I mean, before, family life was a lot different. Now, ladies more than previously are looking to go to school, and then buying a house, and then buying a car, and getting themselves together, and then finding their match and having a family. Well, IVF, and as well as egg freezing especially, has become more popular due to this. As obviously the age for egg quality will reduce after the age of 30, depending on how long that female will take to go to school and do everything else, it could be past that point. So egg freezing is becoming a lot more popular at the moment, so that that lady can then later on have the quality of the egg age of 23 later on at 35. So that's one of the things that are becoming a lot more popular now, as well as the PG tools as well. This is the slides here. Patient satisfaction, of course, very important, especially streamlining through the UK. Obviously, working with people in any area is difficult. Keeping everyone happy is especially important through each phase of treatment, especially with IVF. It's a very sensitive subject with emotionally, financially, and other things as well. So we do our best to keep everything as empathetic as possible at the same time. It's just a patient satisfaction survey that goes through from what we've been getting over the years. You can see we've done quite well. This is for the UK. They're not doing too bad either. So these are what has happened for us in 2015. As we said, we've got the first NHS contract working together with us, which is from the University Hospital at Leicester. We do have a new quality system certificate from QHA Trent. We've had them come through from the UK and gone through our clinic and have seen us qualify for the accreditation. We do give a Rosenblatt guaranteed at the moment. So if in case that the patients are not able to be provided with blastocyst embryos, which are day 5 embryos at the end of their cycle, we get them to come through for another cycle to be able to provide that for them. We do have a 78% success rate this year, which is quite high, which is another reason why a lot of come through to Cyprus. These are just some of the clinics that we do work with through their areas that we work through in the UK. As you can see, there are quite a bit of clinics that are working with us together at the moment, and the success rates are definitely a reason as to why they are wanting to work through with us, as well as the success of the liaising in between. It's a very easy, streamlined procedure. So, role of the international coordinator, just myself and Claire England, who's not here with us today, but she basically takes care of everything on the UK end, and I take care of everything down in Cyprus. The need for coordinated service. People can go through and find what they want to find on the internet. It's so easy now. Google, IVF, where's the best place to go? What should I do? Internet can be a good thing and a bad thing in many ways. People put out prices and give guarantees and sorts of things. We've personally called different IVF clinics and put into comparison. I've made a phone call to Spain, which is a very big point at the moment for IVF as well. And what I've noticed there is getting on the internet, it's quite easy because everybody can speak English and use Google Translate and that sort of thing to make themselves appear English speaking and that sort of thing. Now, getting on the phone with them, you'll find that no one can actually speak fluent English when you get there. So it's very difficult for well, myself at that point, but patients as well, in communication. And communication is very important with the patients. They always have a lot of questions to ask, and they just want to know that everything is going to be safe and it's a good place to be going through. Now, in the UK, having a UK coordinator here, what we'll have is the clinics here in Cyprus will go through, do the monitoring, be in contact with the patient, tell them about what's going on, how it's going to happen in Cyprus. They're able to start their treatment here in Cyprus, or sorry, here in the UK, and then just come for the final transfer in Cyprus, which makes a big difference on how easy it is for the treatment. They get the care that they need here at the standards that are obviously qualified physicians. We're able to contact each other and have all the information every step of the way for the patients. Now, what we do as patients, obviously, it's a step-by-step process. So first we'll email the patients, get into contact with them, see exactly what they want, how they want the treatment to go forward. They have all their contact information, would be phone, email, Skyping, that sort of thing. So we're always one-on-one contact, which is very important and brings ease to the system. We have the UK patients when they need to be there face-to-face for monitoring scans, blood tests, and all of those. So potential term.
You can sum it up.
Yeah, that's basically what I want to go through. Basically, it's just some of the problems that we come to going through is basically what's listed here. Just the recipient not being prepared, having a flight canceled, or personal issues, that sort of thing. We do come into contact with these sort of things, but there's always ways around it. We can have that person's treatment delayed or canceled, depending on what happens. And because they have the treatment monitored here, they can go forward with the help they need and doctors. PG frozen embryo transfer. Just one of the things that we do, frozen embryos get transferred to the patient. It's quite easy. We usually generally obviously use theirs for a second cycle in the case of a negative, or if they'd like to come back for a second child. You only need to be in cycles for 3 days. One on the way here, the day of transfer, and then the next day they can leave. So it's very easy in that way, as opposed to being in a place abroad for an entire month for treatment beginning to end. And that's again because we have the monitoring that can happen here in the UK. PGD had, Sarah went through a lot of the details about PG, and we have a lot of interest in genetic diagnosis and selection, gender selection at the moment. That's more family balancing. If we have a girl, maybe later on you can have that boy that you would like, or if you have a boy, you always wanted that little girl, you can come and have that chosen through the genetic testing process. Also, a lot of patients who have familial genetic diseases, we can screen for those and then have healthy baby results in the end. So just bits that happen on return to the UK. It doesn't just end with the monitoring and then send them off to Cyprus. Once they return back to the UK, the doctor here is sent an outcome form so they can follow up with the patient. They'll have their 7-week scan and then passed off to the GP. Thank you.
Thank you very much, Reha. And I understand that it is almost the last minute. She just come up and have that presentation. And thank you very much coming all the way from Cyprus. And I think it is very important to see this presentation and this business model for health tourism. You can see the link. UK and Cyprus has been set up with the certain criteria and UK standard, which is helpful to carry on as a long-term medical tourism and benefit of the patient. So now we are going through question and answer time. If we manage, we are doing really well. If you manage that question answer time in 10 minutes, we can have another presentation, maybe Dr. Reha Yavuzer able to have his presentation, which is going to help for him to catch his flight back. Can we, now I would like to remind you our speakers. Dr. Mehmet Atasever introduced us about healthcare reform in Turkey. Dr. Timur Timurkaynak, healthy lifestyle and heart disease, and Dr. Figen Karadag about gambling addiction, Dr. Sağlık and Ibrahim taking about IVF outcomes in Turkey and others in Cyprus, but their success rate is quite high, and the way they are working is, I understand, very important for the UK. So if you have any question, please raise your hand. Yes, I think it is right to give first word to Ali Demirbag, and maybe you would like to say something about our panel as well.
First of all, I would like to welcome guests from abroad, distinguished guests, friends. I would like to welcome all the guests from abroad, distinguished guests, consulates, honorable MP, I can't see anybody here. First of all, I would like to say a few words about Councillor Jennifer Mann, who wasn't here. She couldn't make it. Our Madam Mayor of Haringey, she sent her apologies for not being here and appreciating the whole work ITSEB is doing so far for the community, for the healthcare profession, and for the international. Thank you. My question is to both IVF, to several, is what is the success rate in your experience of IVF? And second question, if I not misunderstood, there is allowance of the parents to choose their child's gender. Is that right? The second question to Cyprus, because we're talking about the genetical choice.
Şimdi şöyle, tabii ki başarı oranları hastaların özelliklerine göre değişim gösteriyor.
Success rates change depending on patient circumstances.
İyi hasta grubu dediğimiz genç kadın, hiçbir sorunu yok. Erkek infertilitesi mevcut. En iyi hasta grubu dediğimiz hasta kadın yaşı genç.
Outcome group, young woman.
Ve hiçbir problem yok. Yani bu hafif bir erkek infertilitesi. Tabii ki bunlarda oranlar gebelik oranları %60-70 gibi oranlara çıkıyor. Fakat
Male infertility, if there's a male infertility, there's a chance of having a baby is more than 60%.
Çünkü son yıllarda IMSI ve mikroskoplarla mevcut spermlerin en iyisini seçme imkanına sahibiz.
Because of the technology, we are able to obtain the best sperm from the amounts.
Fakat kadın yaşı 45 yaşlarına çıktığı zaman gebelik oranları %5'in altına kadar inebiliyor.
If woman age become more than 45, it can be chance of pregnancy as low as 5%.
Bütün ileri tekniklere rağmen gebelik oranları kişilerin fiziksel özelliklerine, tedavinin yanıtına göre çok değişkenlik gösterebilir. Yani %60-70 gibi ve %5 gibi oranlarda değişim gösterebilir.
Despite the high technology, depending on the patient circumstances, it can be very that success rate between 5% and 7%.
Bizim merkezimiz bu alanda 20 yıldır hizmet veriyor ve son terminal merkez gibi hizmet veriyoruz. Yani Türkiye'de netice almamış hastalar genellikle bize müracaat ediyor.
Our center is working nearly 20 years and described as a terminal center, which means patient who hasn't had the success from other center, they come over to our center.
Ve bu saydığım ileri teknikleri kliniğimizde uyguluyoruz ve bunlarla da bu zor hasta gruplarında da çok iyi neticeler elde ettik.
In that challenging circumstances, our rate is above the average, and
yani bu zor hasta gruplarında da bu ileri tekniklerle neticeler elde etmek mümkün zaten.
Using the high technology, they had higher success rates.
Ben ikinci soruyu anlayamadım.
Being able to select the gender of the patient's embryos, obviously. Now, at day 3 or day 5, depending on which day the biopsy is done, blastomere is removed from the cell and from the embryo. Sorry. Along with the huge list of genetic diseases and mutations, the XX and XY chromosomes are also able to be seen with the genetic diagnosis testing. So when we get the all clear for which genetic diseases, mutations each embryo may contain, we are also able to see which ones are male and which ones are female, and therefore only transfer either the XX female or the XY male embryos to that patient, which in that case will give them either the male or female that they are looking to have. And we do have a lot of interest, especially from areas like Pakistan, where there's a higher social input for.
You have no ethical conflict.
And now we do have to have, if you, the one thing that we do need to see is, I mean, if you have a son already, then you can have a female, or if you have a daughter already, then you'll go ahead and have a male. You need to have one child previous to doing it. That's why it's called family balancing to gender selection.
Okay, so
sorry.
Just relevant to this point, that was raised huge issues, huge ethical issues. That certainly we haven't gone down that route, and it's something that is banned in this parliament, in this country, for the very ethical issues that you'll see some countries abusing that technology. But it raises a big ethical issue. I mean, don't probably want to necessarily go through that ethical debate today, but I just wanted to note that from this country and this parliament, we are very much involved in the debates and the ethical challenges around selection of embryos, but particularly Parliament's drawn a line in terms of sex selection as being an appropriate form of selection, recognising, as some do, the importance of tackling diseases and obviously using technology to probably attack diseases, but the issue of sex selection does seem to take it a stage too far, so as far as our country is concerned.
Thank you very much. I have a question, Mehmet Atasever. You know that the Syrian refugees are now almost near Türkiyeli. They are given healthcare in Turkey. Could you a little bit elaborate this work on the healthcare system and what kind of measures and international aid we need for that? Thank you.
Teşekkür ederim. Bildiğiniz gibi 2011'den beri Suriye'de ciran canavarlar sebebiyle yaklaşık 2.100.000 Suriyeli Türkiye'de bulunmaktadır.
Since 2011, around 2.7 billion Syrian refugees are in Turkey.
Bazı şehirlerimizdeki Suriyeli mülteci, Suriyeli misafir sayısı bu şehrin nüfusunu bile aşmıştır.
Some of the city has the population which is higher than existing city population.
Mesela Güneydoğu'da Kilis'te ilimiz var.
For instance, the city called Kilis.
Kilis'in nüfusundan daha fazla Suriyeli mülteci var.
At the moment, Syrian refugees number are higher than Kilis population.
Bizim aslında Kilis'te Sağlık Bakanlığı'nın ihtiyacı olan mesela 150 yataklı bir hastaneye ihtiyacı varken
in Kilis, normally they need 150 bed hospital. 150,000.
bu ihtiyaç sebebiyle 150 yatak daha, 200 yatak daha yeni ilave hastane yatağı yapmak zorunda kaldık.
Because of that demand, Minister of Health has to increase that bed capacity up to another 2,000 bed capacity. 200,000.
Bu Suriyeli misafirler için ülkemizde yaklaşık 10 milyar dolar civarında bir harcama yapılmış.
The expense of the Syrian refugees so far is 10 billion US dollar.
Onlar için tabii mümkün mertebe en iyi şartlar sağlanmaya çalışıyorlar. We
have been trying our best
ücretsiz bir şekilde eğitim hizmeti alıyorlar.
All of children are getting education free of charge.
Hatta üniversite çağına gelmiş öğrenciler sınavsız bir şekilde üniversitelere kabul ediliyorlar.
If there is not to go to university, they go to the university without exam.
Ve bu 2 milyon 100 bin nüfusun tamamı aynı zamanda ücretsiz sağlık hizmeti alıyor Türkiye'de.
And that 2.7 million are getting healthcare free of charge.
Yani özel estetik maliyetteki sağlık hizmetleri dışında bütün ihtiyaçları, büyük ameliyatlar, gerektiğinde organlar dahil bütün sağlık ihtiyaçları karşılanıyor ve sağlık hizmetleri aynı Türkiye vatandaşlarına verildiği gibi verilir.
They have same rights in terms of getting healthcare services. The other Turkish citizens, they are getting all treatment daily, including organ transplant, apart from plastic surgery and luxury treatments, like Turkish citizen has.
Yine bu Suriye'de misafirlere adaptasyonu vermek için Türkiye'de uygun olanların çalışabilmesiyle ilgili de hükümet çeşitli çalışmalarda bulunmaktadır.
And also there are a lot of work going on to help those guests to adapt themselves to the Turkey and the last life in the Turkey. Thank you.
Thank you. So I can just, I don't mean it. Yes, I would like to ask Mr. Mehmet Bey this question. So most of these refugees are without immunization. So I'm wondering what kind of infectious diseases did they face till now? If did they face any pandemic, or do they expect anything which is unexpected for Turkey? What kind of precaution do they take till now? So this, I will be grateful for his answer, please.
Teşekkür ederim. Bu misafirler Türkiye'de ortadan kalkmış aslında bazı hastalıklar bunlarla birlikte yeniden görülmeye başladı.
Because of having those guests, some of the illnesses which has been eradicated, now we are seeing those illnesses in the on the ground.
Onun için çocuk nüfusun tamamına yakın yeniden aşılanıyor.
Because all the childhood vaccination has gone.
Mesela kızamık görüldü. Aslında kızamık neredeyse Türkiye'de ortadan kaldırılıyordu ama kızamık vakaları görülmeye başlandı.
Measles has been seen. Despite in Turkey, it was almost eradicated.
Çocuk felci gibi hastalıklar.
Polio has been eradicated officially in Turkey, but I understand there are some cases.
Tabii bu biraz da işin kaçınılmaz tarafı. Biz bu anlamda da hem onlara yardımcı olmak hem de vatandaşlarımızı korumak için bütün sağlık hizmetini bir şekilde yapmaya çalışıyoruz.
This is something we cannot avoid under these circumstances, but we are going to do our best in order to secure health of the population.
Biz Türkiye'de Türk nüfus, Türk çocuklar için aşılama oranı yüksek ama Suriyeli misafirlerin çocuklarını da yeni bir kampanya dahilinde tamamını tamam için gerekli aşılama hizmeti verildi.
Turkish children vaccination rate is quite high, but Syrian refugee children, we started campaign in order to vaccinate all of them.
I wanted to ask after Cyprus IVF clinics, the centers you work in the UK with, when complications arise,
do they cover the complications? Are the doctors working with in the UK, or is it just salespersons you working with? Aftercare, preparation, as you described.
Preparation as well as aftercare is done here. We don't just have the patients come over,
And
have
the
their
doctors
treatment in 2
by
days.
medical staff, or who are doing?
All together, they work together, obviously. I mean, the doctor works here, and then they have their staff who's there to help them as well. But depending what the complication is, I mean, anything that happens in Cyprus, we'll take care of there. Whether it means that we need to admit the patient there for care there, then that's what we'll obviously do. If it's something that occurs while they're here, like I said, they have all our contact information as well as the consultants here, and we provide obviously details on the outcome forms of what has happened and that sort of thing. So they're passed on to the doctors here for aftercare as well.
The doctors covering the follow-up problems, or is there complications, or is there complaints?
That's right.
And are you covering that, support that in any way, or not?
Both. We work together. So if there's a complication, we'll know about what happened as well. And the doctor here helps them as well.
The NHS?
Generally, it's private.
Back there. Microphone is coming.
Hi. What I wanted to ask, do you know the triple pregnancy rates in your clinic? Triplets.
To be honest, I'm not sure, but it's very, very. I mean, from last year, I follow I have a database for the UK patients personally, because those are the ones that I work with. You know, because we only transfer a maximum of 2 embryos, triplets is very, very rare. It would have to be one of those embryos would have to split to be for triplets to occur.
Yes, the reason I ask, all triplet patients we look after, the IVF has been done abroad. I have not seen any triplet patients in the UK, and I believe it's the same conditions European law applies wherever the IVF is being done. But why do we get different results with ending up with triplets?
Now, because we work with the UK specifically, our clinic personally has a 2 embryo limit, so that's why we have a very, very low rate of that. Well, what other clinics do, I can't tell you about, because I'm not sure about that. I only know about our clinic specifically.
Thank you. The other thing I wanted to ask, there are some restrictions about sperm donation and egg donation. Does your clinic offer egg donations, especially that seems to be the main issue in the UK?
We do egg freezing and sperm freezing. If you have a partner, a sister or something like that, we can get permission.
No, I mean it's completely different egg.
No.
Right. I think we've got to a point probably where we need to have a. Do you want to ask another question?
Yes, sir, please.
Oh, no, I was about to say we're going to have a break, so if you want to just very quickly,
Yeah, so yes, I would like to ask about the Turkish Health Transformation Program. So really, I'm very, I support that program from the beginning, as a medical student. Also, after a certain training, I've been involved in this in Turkey and put the system well. Just really appreciate what they expressed. But I would like to know, there's a discordance, just when we check results. And just the report says, the patient satisfaction rate went up. I agree with that. But, on the other hand, all the medical professionals are very, very unhappy with after following this health transformation program. And how could you explain that? As when medical doctors, as providers, are unhappy, do you believe that, that the satisfaction rate with patient will be so high? Really, just my personal, as a medical professional, I don't believe it. So how could you explain that?
Okay, let's do our final question. To pass the microphone back to Sue.
hekimlerle vatandaşların mutluluk oranını paralel bir şekilde artırmak hepimizin teorik olarak çok istediği bir şeydir.
Theoretically, it is really our wish to improve patient satisfaction and doctor satisfaction in parallel.
Ama bu realitede, pratikte çok mümkün değil.
Practically, it's not possible.
Çünkü vatandaşların bunun olması için sağlık personelinin üstüne çok iş yükü yükletiyoruz.
Because of the that patient satisfaction, we put extra workload on the doctors.
Bekleme sürelerini azalttık.
Waiting list has been decreased.
Ve vatandaşa istediği zaman bakıyoruz. Peki müracaat sayısı arttı.
And visiting the hospital number and rate has been increased.
Sigorta kapsamına aldık hemen hemen herkesi ve sigortası olmayanların da sağlık hizmetini ücretsiz olarak devlet karşılıyor.
We put under the one insurance umbrella everyone, and also we provide healthcare who doesn't have insurance. They are eligible to get treatment.
Dolayısıyla sağlığa erişimi çok kolaylaştırdığımız için ve kaliteli hizmet vermeye çalıştığımız için vatandaş memnun.
Because of the high accessibility, patients and people are happy.
Fakat iş yükünü artırdığımız için hekimlerimiz bu işten memnun değiller normal olarak.
Because the workload has been increased, that's why doctors are not happy.
Bunun için hekim sayısını özellikle artırmaya çalışıyoruz.
That is why we need to increase the doctors' numbers.
Türkiye'de hekim sayısının sayısal olarak azlığı çok büyük bir problem.
Number of doctors are low. This is one of the important problems in Turkey healthcare.
Yani ister istemez hekimlerimize çok yükleniyoruz, farkındayız.
Whether you like or not, unfortunately, we put a lot of pressure on doctors.
Ama siyasiler çok memnun bu işte.
But patients are happy with that.
Onlar o çok oyalıyorlar. Siyasetçiler çok güzel oyalıyor bu işte.
Okay, this is one of the source for getting vote for politicians.
Ama hekimlerimizin hakkını ödeyemeyiz. Onların sayısını da artarak iş yüklerini azaltmaya çalışıyoruz.
Of course, doctors' work are valuable and we can't pay back, but we must increase their number in order to reduce workload.
Thank you. It's a good unanimous view from the UK and Turkey at that point. We'll go back to the point of a break. And I thank everyone for their contribution, questions and answers, and all the experts that we've heard. Can we go around, of course, to and yes, absolutely. Thank everyone, including the media here, the journalists, for coming, and anyone else I should mention.
You have done an excellent job. Thank you very much. And sometimes we forget there's really hard work, and I noticed Halil has been working for us nearly 5 years.
Can we
More thank yous at the end of the session. We haven't finished yet, but I'll give you people an opportunity to have a quick break, comfort break, corridor, and just to stretch your legs until we come back again in 10 minutes' time. Thank you very much.
He has wonderful opening hours, and many constituents tell me that they're so pleased that the chemist on Green Lanes is always open and always provides good advice. And we know, as a community of people in health, we need good policy, we need good surgery, we need good aftercare and nursing, and And we also need good quality advice in pharmacies, because often a pharmacy is somewhere where people will pop in when they might have complications. So a big thank you to everybody who's here. It's the community of health practitioners that we need, all on message, all saying the same thing to encourage good health in our local population. So with no further ado, I'd like to call on the doctor to give us his speech. Thank you.
Thank you very much again. I would like to definitely thank you all, especially Dr. Demirbag for putting that kind of effort. It's a great honor and privilege to be here. We made that very last minute change with Dr. Demirbag regarding the topic, and we want to make a minor topic and to get a chance to announce one more thing. Today's topic is the role of women in today's world and in relation with plastic surgery. Just one single word about me. I'm a plastic surgeon, trained partly in UK and US, and mostly in Turkey. And why women? Well, taking the chance of having the Medicine Day so close to International Women's Day, I want to focus on the relation between the woman and the plastic surgery and what that kind of an impact on our world. Well, looking at the Women's Day, the first is noticed by the United Nations back in 1910, and Turkey soon after approved that day as well. Since 1921 in Turkey we are also celebrating the International Women's Day. Women, well, that's a very important subject or personality or anything that you can call for a plastic surgeon just like me, but why is that important? In this society, when we look at the woman, it's mother, obviously, and it's a kind of worker as well for the clinical point of view. But what's the importance on top of that? Well, I think, and we can prove this scientifically as well, the woman brain and the male brain work slightly different. And it has a huge impact when they become a leader, when they become a governor or politician, artist, scientist. So we really need that. Well, on top of that, it seems that most of them are more logical than men come, and they have multitask oriented, as well as they have a greater ability to do organization. So these are slight differences when you compare to male and female. However, they have two things. They're very sentimental, and they also have a role of beauty in the world. So that's also different from men as well. Well, saying all these, what about the self-esteem and self-confidence of that particular gender? Well, if you improve the self-esteem and self-confidence, we know that the productivity of that person is increased tremendously. And that has a huge impact on the society in terms of all matters. When we look at the definition of the health through the World Health Organization, it's not just being healthy without any disease, but also it has being a socially well-being person. Well, what does that socially well-being mean is a self-confident person who likes himself or herself in good manners, and with the aging line, as we are getting older and older, to become gracefully aged and become much more youthful. So those are the things that we need. We want to age gracefully, and we want to live longer in our best, so that we will be more productive to our society as well. What about economics, health economics? When we look at the health economics, we just heard from our Turkish Minister of Health member that we are spending a huge amount of money for the Turkish population, same as well probably in UK as well. Looking at all the countries, almost 1/6 of the entire budget goes to the healthcare system, so it's quite important impact. And when we look at that figure, it's mainly for disease prevention and mainly for certain preventive medical issues, but not really social well-being. So the social well-being is still untouched and left to the patients to their own budget. From that perspective, plastic surgery and a subdivision of plastic surgery, which is the aesthetic surgery, plays an important role, because the plastic surgery with the help of the aesthetic surgery plays an important role for the social well-being, and that's covered by the patient's own budget. And that's why the medical treatment is so important worldwide because people are traveling all around the world to get medical attention. And when you look at the figures from different countries, it's increasing tremendously. Well, what about the relation with the plastic surgery and that medical tourism? If you look at the figures and the numbers that's worldwide, the plastic surgery seems to be the number 3rd medical specialty who has been attended for medical tourism. So it's important. And why it has been that much importance? It's all because we want to increase our self-confidence and self-esteem. Although it looks like a little bit selfish or just related to beauty, it has a huge impact on the society's productivity and economics as well. Well, we want to be beautiful, we want to age in a better fashion. And is it just only the Turkish population that I'm facing at home at Istanbul or worldwide? Yeah, it's a kind of worldwide design. That's why we have a plastic surgery league. And if you look at that league, there are multiple countries on that league, being the States number 1. But however, Turkey is on the list as well at a very higher rank. Is it just the service that we are providing? No, that's the drive creates a lot of research as well. When you look at the scientific research and paper production in the plastic surgery field, also we have a league. Unfortunately, Turkey is at quite high in that league, which is a kind of a proud issue for us. So what's the demand or what's the desire from the female population for that plastic surgery to increase their self-esteem and self-confidence? Well, it seems that we're all getting a little bit fatter. We heard from our precious cardiologist in the previous session that the obesity is one of the most important things, and that's why the weight reduction procedures has a big importance. This is followed by breast surgeries, and then the aging process has an impact on our facial experience, and that's why we have facial rejuvenation procedures. Body contouring, when it comes to plastic surgery, is a complete unit which has both surgical and non-surgical options. And with using all those things, the main aim is to increase our body habitus in a much better fashion and get rid of unwanted fat tissue to a certain degree. Well, when we talk about the breast, well, it's not only the aesthetics that we really should talk about, and there is a topic today that we will be talking about breast cancer incidence as well. Breast reconstruction is very important, and you cannot imagine how much importance to have a breast reconstruction following a mastectomy for breast cancer as a kind of an impact on that patient's life and productivity, both socially and in the working environment for their future life. That is why we have a special focus on breast surgery and breast reconstruction. We run international breast courses at home at Istanbul, which has live surgeries. And throughout the world, we are accepting plastic surgeons to give their best for that course. And we try to give our expertise, and we want to share our experience as well. With that opportunity, we received the Center of Excellence title from US for that courses, and we increase these courses and start doing that internationally abroad as well. What about the aging? Well, inevitable, obviously. Regardless of male or female, we get older and older. However, females has a little bit of more disadvantage, not only because they have the position of carrying the beauty on themselves, but also with the effects of the hormones, they tend to age a little bit earlier than the male counterparts. What happens? We lose our collagen tissue and the wrinkles comes ahead, and the gravity also pulls down certain tissues. And unfortunately, the facial appearance becomes a little bit older. We lose our youthful appearance and restful appearance. That has an impact on our working environment as well. So we wanna achieve something in that perspective for our female inhabitants. Are we going to do anti-aging procedures? No, not really. That's a kind of an term that we don't want to use because we should be acting more proactively. So we want to do certain things before the aging process starts, and that is called age management. And that age management is a part of social well-being in the definition of the World Health Organization. Well, what we're going to do with the age management, it's going to involve a lot of issues, starting from the diet, and we'll continue with the exercise, lifestyle, and at the end, maybe at some point, plastic surgery. Well, if you do good age management, you can see as like in these ladies, after even several years, they look quite nice and aging gracefully, not unnatural at all. Males, same thing as well. You know, if you look at these male well-known figures, you can see that even after 20 years, they be pretty much the same. So they are productive and continuous in the world. Well, if you see and look at this gentleman here that you all know, even after a very short period of time, if you don't take care of yourself nicely, and if you are really under too much stress, then you age prematurely. Well, then what are we going to do with our beauty? We have to define, diagnose, and treat accordingly, because at the end of the day, this is a kind of a medical approach that we need to do. So what we're going to do is define today, diagnose today, and then also look for what's going to be needed in future. How we are going to do that? Through a plastic surgeon or a dermatologist, we want to clinically diagnose the current situation regarding the anatomical basis, regarding certain areas, and regarding to our best of our medical knowledge, which is worldwide. Then from an aesthetic point of view, like through a beauty coach or an esthetician, we want to define the beauty concept as well, because it has been changing over the years due to the fashion, due to our habits, due to our changing lifestyle as well. Well then, the technology moves into the picture, which through the 3D images and skin analysis systems, we start to diagnosing many other issues that we can't see with our eyes. And that will help us to document these so that it's going to be a scientific foundation at the end of the day, so that we can compare what we are doing and what we need to do as well. Once that has been done, is that enough? No, I want to know a little bit about the future as well. And in order to know about that, we do the genetic analysis, and through that genetic analysis, we figure out how you are going to age, how the wrinkles, the pigmentation, the skin colors, how those will go away or come over a period of time. Then once that has been done, the diagnosis is there, and it's the time to define the protocol, how we will be following you over the period of time, so that you will be in your best shape. And that's going to be created according to your age, according to your position, and according to what you will achieve. Well, of course, through that, we created a kind of an educational system as well, and with the collaboration of UK, Germany, Holland, and Turkey, we created the Advanced Aesthetic Institute, which the center is currently in Germany, and then we'll continue with that. Obviously, we don't want to achieve any unnatural results, and nobody would like to achieve, and that's the big responsibility of the plastic surgeon for that. Woman figure is a kind of a very difficult figure because much more responsibilities than the male has. And in that sense, when we look at the plastic surgery for women, it really helps for the social well-being, the self-esteem, and to improve the self-confidence. I want to thank you for this opportunity. Thank you.
Thank you very much. Now we'll be hearing from Dr. Ali Demirbag. Dr. Misro. Dr. Misro has 10 minutes to talk to us about his important work, surgery for victims of war. Everybody here a presenter? Would you yes?
Can you ask us any corner? Can they hear me?
Yes, right.
So, this is one of the pictures from the Second World War in the island of Birliği. It's now in the New Papua Guinea. This is one of the this is a glimpse of a new age theatre performing war surgeries. So we'll go through the journey as to how things have evolved over the last 6-7 decades and where we are right now. There are war news and news of mass casualty in the news every day with the war victims, and in the civilian areas also we are having a lot of mass casualty. So we are going to look how this war science or the battlefield surgeries they have translated into improved healthcare in the civilian areas. So in the Vietnam War, which was fought between 1955 to 1975, 1975 to the First Gulf War, there was a growing need for rapid evacuation of the war victims at a rate which is out of proportion to the resources at the war zone. So in addition to that, there was a lack of uniformity between how they code the procedure, what's the pattern of injury, and hence there was not a system in place to systematically analyze the patient outcome, to capture and track the patient outcome, and to translate it into a clinical guideline. In 2001, so I will refer the OEF stands for the Operation of Iraqi Freedom, and OIF stands for Operation of Enduring Freedom in 2001, and Iraqi Freedom as well as 2003. So in my next 10 minutes, I'll be referring them to OEF and OIF. So these, in 2003, the Surgeon General of US Army, he dispatched his team of top consultants to Iraq in a fact-finding mission to see what's wrong in management of the war victims and how it can be improvised. So what he basically said is, go and find out what's wrong and fix it. So following that, the top consultants, the battlefield consultants, including orthopedicians, general surgeons, plastic surgeons, and the anesthetists, they went for a fact-finding mission and found out the lacunae of the system, and what they recommended is called the JTTR. So JTTR is basically the Joint Trauma Theatre Registry, and this is a codified procedure where we can code a particular injury in a way and can outcome and track the outcome. So going to one aspect of what has improved is historically we know that 20% of the casualty victims following the war, 20% of the death is due to the exsanguination, is the massive blood loss. And this exsanguination is almost half of the potentially preventable death, and 20% could be preventable if there could have been a system in place or a device in place to stop the bleeding. So in 2003, for a research by Perkin et al., they found out that they devised something called a modular tunicate. And this is how it looks like. And initially, following the recommendation and the real feedback from the real world feedback and the research by US Army Institute of Surgical Research, the Combat Support Hospital, they distributed almost 40,000 tunicate by the end of 2004, and it was so successful that now it has become a military doctrine to apply the tunicate if there is any extremity hemorrhage, and it has saved a tremendous amount of life and a significant early survival in patients. If you look at the textbook written before 2000, it will say tunicate, no. But now it has become established part, not only in the warfare in the war zone, but also it has been translated into the civilian surgical service as well. However, we cannot overemphasize the importance of the local pressure dressing. The second aspect of this evolution in the war surgery is that initially we were talking about hypovolemia contributing to the death, and we talked about euvolemia and resuscitating the patient. But what came out in last 1 decade is that over-enthusiastic resuscitation, aggressive resuscitation, leads to survival from the initial injury only to succumb very soon from other injuries like multi-organ failure, and that results from the triad, which is called the lethal triad: hypothermia, acidosis, and coagulopathy. And this leads to organ failure, infection, and ALI, acute lung injury, or what is called as the acute respiratory distress syndrome. So as you can see this graph here, the early death is just shifting its pattern to the late death. So early death, that peak has disappeared, and the late death, that has increased following the aggressive resuscitation. So now what is being practiced is called the hemostatic resuscitation. That means early use of blood products like whole blood, not whole blood, the packed red cell, cryoprecipitate, plasma, and the platelets. There has been a landmark paper by Bogman and colleague which actually changed the whole practice in the military surgery. Now, if there is a need for massive blood transfusion, the early institution of blood and blood product is something which is very common in practice. And previously, as I discussed lethal triad, previously it was known as the trauma-induced coagulopathy. Now it is known as iatrogenic coagulopathy or resuscitation-induced coagulopathy. So to combat that, this one we discussed that how Bogman and colleague, their landmark paper, has totally changed and made a paradigm shift in the management of resuscitation. Now this is a new thing which has emerged in the last 1 decade, is the hypotensive resuscitation, keeping the blood pressure on the lower side, and this has actually shown to significantly improve the mortality. Actually, the NICE guideline says now that if the ambulance person is retrieved someone in the civilian zone, and if there is a pulse rate, radial pulse palpable, they are not supposed to administer IV fluid except for head injuries. And if the radial pulse cannot be felt, they are supposed to give only 250 ml bolus of IV fluids. We have learned in the hospital setting that how to manage a patient, an acutely injured patient, A, B, C, D, E. But in the war zone, the A, B, C, D, E is replaced by C, A, D. Thus, we go for the circulation first, airway, then the breathing. Because circulation is reached to early death, and circulation can be managed in the battlefield. So it's a realistic problem which can be easily managed. Damage control philosophy, this has been the backbone since last 10 years, and we talked about backbone damage control surgery back in 1980, where it was used. It was actually a borrowed concept from Navy, where the plan was to keep a ship afloat despite any problem. So basically to focus all the resources to keep the ship afloat. Now this damage control is applied now to surgery, and here the main aim is 3 main goals: is to control hemorrhage, prevent or block limit the contaminations, and apply temporary abdominal closure. So to save life and limb all the time, that's the philosophy of damage control surgery. So this is what we talked about 2 decades ago. Now, damage control surgery in the civilian zone, aggregated operations followed by ICU resuscitation and the definitive operations. Whereas the military damage control surgery, which is on the right hand side, extreme to the right, 4th one. So we do a level 2 surgery, level 2 resuscitation, level 3 surgery, level 3 resuscitation, and then evacuations, then level 4 resuscitation, level 4 surgery, and then transfer to the global wing evacuation to level 5 and the definitive care. So it is a multi-stage procedure and a multi-stage resuscitation. So control of the hemorrhage, and this is what we do it very quickly and swiftly, packing of the abdominal cavity, arresting the hemorrhage and doing the procedure as much as necessary. And leakage control by applying clamps and staples. And temporary abdominal wall closure, and this will be addressed. The abdomen will be left open and it will be joined at a later stage when the patient is out of the critical phase. So, and the most important thing is to prevent hypothermia at all costs. And the future is that there has been a lot of research, ongoing research, and the warfare surgery as to how it can be applied, how the patient outcome can be improved, like the hypothermia, etc., etc. Now, the pendulum has swung in the other direction. It is found that now the damage control laparotomy is being overused. The surgeons are feeling it more comfortably to use the damage control surgery. Hence, the indications for damage control surgery is being redefined. The absolute indications being very sick patients, which can be evidenced by hypotension or the metabolic parameters or coagulopathy or operative coagulopathy. So if these are the things which are present, then to go for damage control surgery, otherwise to do a definitive operation. And some of the new developments like optimally utilizing hypothermia, etc. Thank you very much.
Thank you very much, and thank you for keeping to time, because I know that there was a lot in that, and you expressed it in a very concise way. I'm sure you'll have lots of questions. So now I'd like to turn to Dr.Halil.
Very good pronunciation. So I'm Mr. Kadioglu, one of the consultant surgeons working here in London. So I'm dealing mostly with breast cancer. Today I'll try to tell you about metastatic breast cancer. It's quite a boring subject, you know. I know not to face anybody in his own family, something like that. But unfortunately, so in this country we diagnose about 50,000 new cancers per year, and about 5% in some places might be even higher. Up to 10% from the initial diagnosis we might face metastatic breast cancer, which means spread somewhere else. So it means that we are facing every year at least 3,000 to 4,000, metastatic breast cancers. Next. I would like to dedicate this presentation to one of my previous professor, Metin Ünal, and I have few names here, White Özmen and Professor Soran. The professor is the head of the department in Pittsburgh in America, because they completed the Turkish trial, which was very important for us, for description of metastatic breast cancer, and it was MF07 trial. This is the trial. And we know that when we diagnose cancer, even just later on, even in a very early stage, up to 30% of them will change. In some point, will show spread somewhere else. So next one, please. And when we diagnose somebody with cancer, even in metastatic setting, it's very important to know the response to hormones, which means estrogen, progesterone, receptor, which is epidermal growth factor. And because it's very important for us, why? Because if somebody is responding to hormones, even giving hormone treatment, anti-estrogen or inhibitors, we might block the disease for a while. But unfortunately, we don't have the same chance, when we have triple negative cancer, which means estrogen, progesterone, and receptor negative cancer. And the other problem is still we don't know, although there are a lot of investigation, research is going on, why just in triple negative cancer we face more soft tissue spread, soft tissue metastasis than bone metastasis. And where in the northwest London, we have a lot of African background ladies, black ladies. We don't know why the triple negativity, the hormone response is negative in these ladies, although the global, just the rate is around 15%. In the African black population, it goes up to 35%. And even early diagnosis of cancer, early breast cancer, when we face this triple negativity, really just, we have not very good memories, and it's very unpredictable, the general behavior of the cancer. Because when we are giving somebody, this hormone treatment, we can work the disease up to 52%. But when we are facing triple negative cancer, we are losing this 52% chance directly. So that's why it's very important. The first thing in metastatic hormone metastatic, we check this hormonal response. Next one. And the next one. And just we have in metastatic setting, systemic treatment options, endocrine treatment, chemotherapy, targeted systemic therapy, radiotherapy, which might be just, direct to the blood, to the central nervous system, surgery or surgery lesions. I'll discuss it later on because there's still a big question mark when to operate this kind of patients. Is it real? Are we really adding anything to their life expectancy or not? We have it's a quite big question mark. And it's palliative medicine, of course. And as I told you before, when we are facing hormone positive cancer, at least we had initially some options to block the cancer even in metastatic setting. And later on, just we can add chemotherapy, although it's a palliative, still just we might extend the life. But in triple negative, directly we need to proceed with the chemotherapy. In HER2 positive cancer, of course, we have some more, just chances, giving Herceptin, we might block the disease for a while, we might have a slightly higher chance. Next one, please. Although, just a lot of research and a lot of studies going on throughout all those years, we couldn't increase the median survival rate in metastatic setting. And as you see here, just in distant metastasis, in African ladies, the percentage is higher. In white ladies, 23%, so it's again related to triple negativity. So that's why it's higher. Next one, please. Just to give you a brief information how we stage the breast cancer. T1, when the cancer is between 0 and 2 centimeter, and there is no lymph node involvement, this is stage 1. Next one, please. Stage 2 is when it's between 2 and 5 centimeter, and there is no lymph node involvement, or there's a lymph node involvement, but the lymph nodes are very small, they are not attached to each other. And the stage 2 will be again the same, just T2 and 1. And the next one, please. Stage 3 is when it's more than 5 centimeter, when there's a lymph node involvement and there is no spread. And stage 4, the next one, please. Stage 4 is when we have spread somewhere. It might be the spread to soft tissues, mostly in breast cancer we see to bone or to skull, to brain, to central nervous system. Or that still we don't know why in triple negative cancer, when there is not a response to hormones, why we observe more soft tissue spread than bone. So still a lot of studies going on. There are some studies, is there any chance to change this response to hormones? Promising, non-promising, it's very early to tell something. The next one, please. Just to mention about, the nature of this spread, why the spread is taking place. So that's, basically this is the most, acceptable scientific explanation. EMT is the epithelial mesenchymal transition, and so it goes through the extracellular matrix, it goes inside of the vessel, so it means that it becomes a circulating tumor cell, and it's extravasate and it goes somewhere else, so that we see the metastasis. There are a lot of studies going on now. When we directly just remove the metastasis, the spread, even just, in a lot of studies, it has been shown that the primary cancer is growing up faster. So that's why just, there's a big debate about it, when to remove the metastasis, this spread part of, the cancer. So we are every day we are learning new new things, and I think in the near future, you know, knowing more about molecular biology, more about the circulating tumor cells, we will know more about it. So next one is about the same. And we have a lot of basically questions to answer. You know, just whenever we are answering one, we are very, of course, we are becoming very encouraged. We are encouraging our, you know, society, our patients, but still we have a lot of unknowns. Next one, please. Bone metastasis, you know, we are very successful to treat bone metastasis because, you know, giving radiotherapy, we can control things. Even with surgery, with early surgery, with prophylactic surgery, we might, you know, prevent from fracture. Okay, next one, please. Again, just, you know, just for the, this again, more scientifically. For me, it's more important when, you know, to perform surgery for stage 4 for metastatic breast cancer. There's a Turkish study, you know, done, you know, just a few years, 3-4 years ago, which was presented, you know, San Antonio, and this is a very well organized trial, randomized trial, basically. Just could you show me? There's a 2 arms, you know, just one arm giving systemic therapy, and following that, you know, to observe the local therapy and local progression, and then to check the overall survival, or initial local therapy, breast and axilla plus systemic therapy. And when we, and also there's another good study done. Again, this is, you know, the published data about the Turkish study. And the next one, please. Yeah. These are memorial Indian study. Also, this one again, it just basically, with 350 patients. There are some differences because in that one they didn't use a lot of Herceptin, as in the Turkish study, which might affect the result. But these both studies, they didn't show any survival advantage of surgery, except the Turkish trial showed a survival advantage when there's only bone metastasis. But if there's any soft tissue metastasis somewhere else, there is no survival advantage of doing any surgery. So that's why it's very difficult, you know, to be aware of all these ongoing trials. And we need, of course, more prospective trials, more randomized trials. But I think it's also very difficult to randomize those group of patients. Why? Because they are deteriorating in a short period of time, and there's different ethnicities, different, you know, beliefs, religious are affecting factors, you know, to randomize them to different groups. Just next one, please. Yeah, and the next one. Okay, so just I mentioned that there's no big survival outcome. The next one, please. Yeah, and there are some more studies going on. Just I think just nowadays. Next one, please. Now, just there's a big emphasis on breast cancer stem cells. Unfortunately, you know, for breast cancer, we are very unlucky because in different studies, the rate of identification in peripheral blood, the circulating tumor cells, which means basically we can say breast cancer stem cells, about 19%. It's quite interesting, you know, the identification of cancer stem cell in colon cancer, large bowel cancer is up to 70%. Probably in the near future we might find more solution about bowel cancer than breast cancer. It's quite, you know, depressing to see the rate of the stem cell, only 19%. But there are a lot of studies going on about, you know, circulating tumor cells. We know that even with the initial diagnosis of metastatic breast cancer, if the number of the circulating tumor cells, which we can identify in the peripheral blood easily, if the percentage is high, we know that, you know, even the palliative chemotherapy is not going to be beneficial, it's not going to show any effect. So what's the point of, you know, really just torturing those patients, torturing the family, torturing, you know, the patient? also destroying the local economy. We need to consider all those options. Probably, yes, I agree with President Obama. I liked, just his, declaration about it. He said, although he is not a medical doctor, he was very clever to say, what if matching a cancer cure to our genetic, coding, just, giving, if we are matching, like when we are transfusing blood, is there any chance to do the same thing for cancer treatment? Maybe the near future will give us more opportunities. If we will be able to know more about, the genetic coding of our patients, we might have more personalized treatment. At least we will know which patient might benefit more from different type of treatments. But again, we will need more research, more money. Probably it's a good place to mention about it, in front of our member of parliament here. We will need more money into the NHS, National Health System, not only here in this country, everywhere. And just the next one, please. We will need more collaboration. I like this picture a lot, that's taken by my close friend Martin during Safari. So we need to think on the same way. This is not only just one country's problem. It's a global problem. We are increasing number of cases, so we will face more and more metastatic breast cancers every year. And next one, please. Thank you. So just I got my question. Are you more than happy at the end or now?
Perhaps at the end, just got one more speaker, and you were mentioning funding, and there is some interesting statistics in here about the proportion that the central government in Turkey is now spending on health compared to 15 years ago. So do get a copy of that. There's some very interesting stats. Now, our final speaker for this session is Dr. Eryilmaz. He's a haematologist, and he's going to be speaking about immunisation in the refugee camps, after which time we'll have a question and answer session. Thank you.
I'd like to thank first Ms. Catherine West for hosting us in the Parliament House and next to House of Commons and House of Lords. And I'd like to thank the ITSEB for inviting me for this presentation at this meeting. This is the one. Although this is not my subspecialty, I'm originally a pediatrician, so I can talk about vaccination. And this is a very nowadays it's quite nice topic to talk about. Not nice maybe, but in general, we are in trouble with the refugees and all the medical details of vaccination. I'll try to give you some details on the talk. Okay. As you know, there are some specific vaccine preventable diseases. And all of those are quite dangerous, and that's why they have serious side effects and they cause fatality, and that's why we need to immunize people to get rid of this side effects or fatalities. Approximately 20 vaccines are currently in use, and new or improved vaccines and technologies are also in the pipeline. As you see, the preventable diseases are quite a long list, and many of them are quite contagious and have bad side effects, especially for those living in young ages, children and young adults. But of course there are some facts. You see the Earth from the space, and you will see under in the Earth what are they. Yes, for example, for a TB patient, if the patient is active, he's going to shed at least 10 to 15% every year who are healthy, who is healthy. And the consequences, global burden, is quite high in numbers, as you see. And total death toll is as high as 4,000 a day in the whole world. You see the rates are very, in 2013, in some parts of the world is very, very high, still high, not in Western countries, but in underdeveloped countries and in many parts of Africa. It's as high as 500 in 100,000 population. And another fact is about measles. Measles is very, very contagious disease. It's also it has very bad complications, especially sort of its respiratory system infections and pneumonia, later on, of course, fatality. And the incidence is still possible in some parts, and in UK as well, because maybe the high rate of people changing, especially in the Commonwealth countries, especially, and the others as well. So the rates are still higher than expected. Yes. You see, in 2015, in Disneyland, the measles outbreak caused most of the numbers occur in United States last year. So it is very contagious, very, very contagious. If, you know, in this, as you see in this slide. And for pneumonia, the highest rate of childhood mortality after neonatal cases, pneumonia. And pneumonia is a preventable disease. If we could be able to immunize the whole global population, these ranks would leave around 5% maybe, because there are still unpreventable pneumonia cases which is not being vaccinated. Okay? So this is for polio. You see, in 1988, the polio rate was in 225 countries, was as high as 350,000 cases. And it dropped miraculously up in 2010.
So, since we are here nearly 4 hours, it is little shy than 1,000 refugee units. In 4 hours, almost 1,000 people moved there from home. This is the affected area. It is affecting whole English, but now around 280,000 in Europe. This is the Malatya camp. So we are not here to solve the Syrian crisis. We are not here to talk about Assad or other leader, what their view is. This is the situation of how we should deal with the crisis and individuals' rights, that human rights they should have. This is the Malatya Syrian camp. Those, it has around 2,000 containers, which has 2-bedroom facilities, and they have showers, and also they have common areas. Okay, you can see a number of facilities. On the right-hand side, this is the healthcare facilities. Around 10,000 people are living there. And there are 30 doctors working in that facilities.
On the left-hand side, you are able to see supermarket and
almost to 1,300 cases in 4 endemic countries here. But is this the fact? Yes, that was the fact. Please change. But it started to rise again in some parts of the Middle East because of this war. And the conclusion, as you see, is miserable, really miserable for a kid like at this age. And unfortunately, this is a preventable disease. And it was, we were almost about to finish, like other hoax cases, like, you know, and we couldn't manage at the last minute. Okay? Another one is Haemophilus influenza. This is one of the very bad bacteria in the first 5 years of age, which causes meningitis pneumonia. And after that age, the immunity can overcome this bacteria. But below 2 years of age, if we can immunize the kid, it's almost 99% effective. So this is, you know, if after third dose the patient is safe, after third dose, only 3 doses. And this, in 2014, this is the rate of vaccination in the whole world. Is it high? No, it's not high. Yes. Another fact about Hep B. In developing countries, Hep B infection usually occurs in childhood. Hep B is a virus which can be transmitted with blood and sexual intercourse. So how come children can have this sort of an infection so early? That's because of the delivery. Delivery causing this infection at the beginning of their life, and this is causing mortality in maybe 20 to 30 years of age very early. So this is another fact. Chickenpox, it's milder, but it still has severe complications. In some parts of the world, including UK, this is not the immunization in routine, but it causes quite a high complication. And I think the UK also should change their look at this particular disease, because it's preventable with only 2 doses. Okay. And adults. Adults can be protected from 14 deadly diseases. So the vaccinations are not only for children. We can help them using those vaccines. And for example, measles, after the ones who was born after 1957, if he is a refugee to the United States, they get measles in vaccination before they start a couple of months before they apply to the United States for refugee asylum seeking. So these are the facts. These are all the facts. But what happened? You know, the coverage is low, very low. In pneumococcal disease, as low as 25%. And, you know, these are all preventable diseases. Okay? Yes, he deserves it. Next, please. This is a plan, Global Vaccination Action Plan, which started on 2012. And until 2020, they are targeting full benefits of immunization, please, and to achieve a world free of polio, and to meet global and regional elimination targets, meet vaccination coverage targets in every region, country, and community, develop and introduce new vaccines and technologies. We will see. Okay. And also, this is the Global Eradication Initiative for Polio, which is another target for that period. Yes, he is having a polio or vaccination or polio. And Syria, next to Turkey, which is our neighbor, and the worst refugee crisis of our generation happened next to our border, unfortunately. And 4 million Syrian people between, in 4 years' time, you know, lost their everything, almost changed the land, their landscape, and just walking the road between starting from Turkey to Europe and even to the United States and everywhere in the world. Okay. The current influx of refugees, asylum seekers and migrants is unprecedented, not only in scale but also in speed of movement. It's impossible to vaccinate, and the situation is compounded by the fact that many vaccines must be given in consecutive doses, which is not possible. Unfortunately, access to the full vaccination schedule through follow-up vaccinations is difficult to ensure while people are on the move. Nevertheless, refugee asylum seekers and migrants should be vaccinated without unnecessary delay, especially we will be vaccinated against mumps, rubella, MMR, and polio at the first instance. This is the civil war that it takes place. And this is the detaining camps. You know, these are the numbers, not for infected cases. These are all tents in this area. Big one. Yes. This one. They are living in this camp without water, and they sell ice cream. Ice cream in that setting, yes, and try to do the vaccinations. This is from Rabia Bilici, UNICEF Regional Director, Middle East and North Africa. She said, millions of Syrian children are at risk of becoming a lost generation, as they miss out education, vaccinations, and a number of critical interventions. There is no better resilience strategy than investing in the skills, knowledge, and well-being of those children and their future, and the future of Syria depends on them. Okay. This is an example of USA refugee program. They normally examine 6 months before departure all refugees. And after that time, in 3 weeks pre-departure time, they have medical screening. And the ones which has some infections like tuberculosis, they need to be treated. And then fit to fly, pre-departure checks, they get some antiparasitic treatment and vaccinations. You know, antiparasitic is a plus here. Okay, that's good. Okay, this is another program of that United States or other migrants in the area. And the costs are, you know, boosting. It was as low as $0.67 in 2001, and it's as high as 45. 48 times, higher, which is, okay, the next. And also, you see, for a male, it was over $70, and now it's in 2010, after 20 years, it's as high as more than 1,200 something for male children. Okay. And this shows us the global aviation network. We are very close to each other anymore. In just 24 hours, you see. And I'd like to thank you all. Next, please. And also, I would like to give my farewell to the souls of Ankara victims in the last 3 bombs. Blasts, and I want to say farewell to all of their souls. Why? They are innocent. They are all innocent. Thank you.
And also the beautiful dedication. And now our chair is going to have the closing remarks on his topic. And then we'll have 15 minutes for questions. So, Dr. Demirbag.
Thank you very much. Once again, I would like to thank you all, and I would like to thank you for hosting us in that fantastic setting. It has great history in this building. There are many decisions that have been taken related to world and world health. One of the reasons we are choosing this remarkable place to have an event is just we would like to get our message, which is going to be part of the ITSEB message, what we have seen last year. Just I would like to give a little trip about ITSEB, what we do, who we are, and you all know. Just I would like to emphasize and remind us who we are and what we are doing. I'm going to talk about our objective and some of our events, and also specifically for this event, I would like to talk about Syrian refugee camp in Malatya and in France, which I have visited, and I have some reports about that. There is some learning, and I would like to share. I would like to talk about what we can do in order to improve their lifestyle and to give them better human rights they deserve. We have established in 2011, and history colleagues of ours maybe 5 years ago, as you were quite young and I have more hair. So, our objectives are sport medical staff and sport patients, trying to be part of the bridge between Turkey and the UK. But we start doing some of the work in Europe. So we are, I think, proudly saying we are bridge between Europe and Turkey. We have a number of activities which has benefit for the patient, like translation issue when the NHS they cut first they visit translator. We have this culture study, and luckily they have some sort of facilities, but it's not good enough, it's not that effective because they want to do the telephone translation, and language barrier is costing more than providing translator to the NHS. We involve number of health check programs, and also we lobby in number of locations, freedom movement for the doctors and health workers and professionals. We do a number of seminars, and also we have medicine day activities like that, which allow us to raise our voice and make sure our patients' rights and doctors and nurses' rights to be heard.
topic because I am not able to see all of them. Yes, of course, the Irish Journal. Each year we publish one of the journal again part of our book. This is the message we are trying to pass through to communities like FGM against drug and also working together. About Syrian refugees, we moved somewhere. You know, when I looked at this room, we came from somewhere. Steve Jobs' father was from Syria, and he is the owner of the Apple, and it has $8 billion US worth company. He was a refugee. Whenever you see one refugee, you can see one of Steve Jobs' father. So it's simple as that.